We have obviously a large Hispanic population. Although I apologize, I'm Spanish impaired. So I know a few words like preguntas and mucho gusto, but that's about where it ends, so I apologize. Now, if you want to speak French, I do have French. But in any event, I'm a medical oncologist and a geneticist. I trained at Tufts. I was at New England Medical Center for 10 years, been at City of Hope for a little over 20 years, where I started their cancer genomics department. So I was asked to talk a little bit about some of what we do, which is genomic risk assessment, and how do we implement that kind of care. I'm also going to profile some work that reflects on what we've learned in Los Angeles with our Hispanic population there, as well as what we've done so far in Mexico and other parts of Latin America, just as an exemplar of what is possible. And so again, it's an honor to be here, an honor to be part of this proceeding. My first visit as a healthcare professional to Mexico was in 2009 when I visited Adrian Denari in Mexico and other parts of Latin America, just as an exemplar of what is possible. And so again, it's an honor to be here, an honor to be part of this proceeding. My first visit as a healthcare professional to Mexico was in 2009 when I visited Adrian Denari at the University of Guadalajara and had the great honor of actually speaking at the Festival de Livre, at the book fair, on genomics. And so that's been a long, as it will, storied association since then. So next slide, please. So I'm involved in genetics and cancer. So what are we thinking about? We're talking about BRCA1 and BRCA2. Why? Because it's a very high risk for breast cancer compared to an average woman. Women who have a BRCA-associated breast cancer have a very high risk for second primary breast cancer. So BRCA testing in most of the Western world is engaged with management of women with breast cancer that suggests genetics. So ovarian cancer risk is there at 15 to 45%. That's 10 to 30-fold over the average woman. And I will tell you now that, in fact, if you can do nothing else, recognizing a BRCA carrier and taking care of the ovarian risk will affect mortality. So it'll affect both the mortality for the breast cancer as well as for ovarian cancer. So it's really probably the single most important thing about genetic risk assessment in this context. Next. So men are not spared. Prostate cancer that is clinically meaningful is associated with BRCA2. And so, whereas in the United States, the U.S. Preventive Services Task Force currently waffles on whether or not to recommend screening, we would definitely recommend screening for a BRCA2 carrier, and we'd start at age 40, not at age 50. And virtually every stage, we would be more aggressive rather than less aggressive if one is given a choice. Fallopian tube cancer, we now know, is really the root of most malarian or ovarian cancer, because it wasn't until we started taking the ovaries out of women who were BRCA carriers in anticipation, and then did very careful serial sectioning of the tubes, and the fimbriated end of the tube turns out to be the source of most of what we know as ovarian cancer. So while we used to think of tubal cancer and ovarian cancer staged the same way, treated the same way, same kind of clinical outcomes, they are the same. And in fact, 3/4 of what we know as ovarian probably was tubal in origin. But as you know, it's always late stage at diagnosis involving the entirety of the pelvis. And so it's no surprise we couldn't discern that. But it's interesting because it's one of the insights we got from studying hereditary ovarian cancer. Next slide. So this is a timeline of the BRCA genes, and actually more than that. It goes all the way back to Watson and Crick, the original publication. But in 1990, Mary Claire King identified that there was a gene on chromosome 17. It was BRCA, which is breast cancer gene 1. That's how she came up with a name for it. Established it by linkage analysis. So even though it didn't have the gene yet, they knew where it was, and it now existed. And it took 4 years to actually get the sequence reported out. Sequencing was much more expensive and harder then. And that was, of course, by Myriad Genetics as an industrial partnership. And they patented the genes, both BRCA1 and BRCA2, which is on chromosome 13. And then commercial testing has been available in the United States since 1996. Now, in the beginning, it was often called experimental, so some insurance plans paid and some insurance plans did not. Medicare did not pay for at least the first 5 to 10 years of testing that was available. But nonetheless, it's now been 22 years, and in that interval now, Medicare pays, most state Medicaid pays, and virtually all insurance plans pay unless there's a specific exclusion. So that means that there's been a lot of testing that has gone on, and we've learned a lot about how to take care of those individuals. So it's been progressively more integrated in care. Next click. And of course, you can't be in Los Angeles without talking about Angelina Jolie. So, in her case, the thing that I admired the most about Angelina was the fact that she wrote an op-ed piece in the New York Times, and that she was able to get the message to the press that said, it was my choice to get a mastectomy, but it's not necessarily the right choice for every woman with a BRCA mutation. Because one of the things is it is not automatic that they would get a mastectomy, but that was her choice. I'll wait till you mute them. But what the other thing it did was it brought a lot of patients in who had been on the fence, who weren't certain about getting testing. So we all got much busier after she announced her status. Now, the other thing that happened almost at the same time, both of these things happened within a year. The Supreme Court threw out the patent for the genes and said you can't patent genes, like you can't patent a baseball bat because it's part of a tree. You can't patent a tree. So they said that that happened. And what happened right after that is instead of one genetic testing firm, suddenly there were 7 or 8 genetic testing firms, literally within weeks of that patenting. And then the second thing is because the gene testing technologies had advanced so much, we call them next generation sequencing. You heard that at many meetings. It made it a lot cheaper. In fact, if you look at the first human genome, which was published in 2000, the first draft, it's up at the top there, that took 10 years and $3 billion to sequence one white guy's genome. Okay, so $3 billion, 3 billion pieces of code for the draft. Today, you can do it in 2 weeks for $1,000. So it's a huge change in what we can do with the technology. So the costs are coming down. It's becoming more accessible. Next slide. But what I'm really most proud about is the fact that in the 10 or 20 years, rather, that we've been able to do BRCA testing and understand who's at risk, we learned how to take care of them. First off, we still only test adults because we don't change care of anybody who's under the age of 25. So there's no reason to test children. You have a 50% chance of absolving a parent's concern, but you have a 50% chance of burdening the child with risk information that they can do nothing about. So we don't test. The benefit goes to the child. But for the adults, we have everything from preventive surgery to chemo prevention and surveillance. So we know now that mastectomy, when done, is over 95% effective, but a bit barbaric. Oophorectomy, which we would never use an open procedure anymore. We would laparoscopy or robotic surgery, but we now know that that is extremely effective, eliminates the ovarian cancer risk, and reduces breast cancer risk by 50% if it's done when the woman is still premenopausal. So I told you, ovaries are the key. And we now know that removing the ovaries improves survival, overall survival. Targeted therapy, so PARP inhibitors. So we were actually part of one of the first phase 2 trials, paradigm-shifting trials of olaparib as an oral agent given for metastatic breast cancer that was BRCA and metastatic ovarian cancer that was BRCA, showing that as a single agent, heavily pretreated patients, we got significant responses. And now, of course, there's FDA approval for Lynparza for metastatic ovarian, now just recently for metastatic breast because of Olympiad. So I'm not going to go through all of that, but just to let you know that, so we have targeted therapy for metastatic disease. We added MRI to surveillance. We have evidence from prospective studies that if you take and add MRI to mammography, that you downstage the patients. So they're much more likely to be at stage 0 or stage 1 than advanced stage. So we have prospective evidence of that. We'll never get prospective evidence of survival, though, because it is already the standard of care. Nobody will be randomized to MRI or not. So we'll never get that endpoint. But we believe that it'll follow. And then we know that oral contraceptives reduce ovarian cancer risk, just as they do in average women. And tamoxifen probably reduces breast cancer risk, at least in BRCA. We don't know about BRCA1. I think it might, but only if you start early enough. So we have lots of things we can do with that information. So it means that it's more compelling that this kind of knowledge be available broadly. Certainly, certainly tamoxifen is generic and relatively cheap as drugs go. It's like $30 a month. So it's something we could all afford to do. Next slide. So I started the Division of Clinical Cancer Genomics at the City of Hope. This is one of our brochures about how do you outsmart cancer, the Cancer Screening Prevention Program. We do patient care, research, and education and training. And so I've had the honor of helping to teach a number of people who are here today and others who will come forward in the future. Next slide. Physicians in the community, for physicians who want to practice cancer genetics, and for patient education. We do epidemiologic research, which you have in the middle here, and I'll highlight a little bit about our international collaborations and how we've contributed to molecular epidemiology. But I'm very interested in health outcomes as well as health disparities in promoting access to care. Next slide. All right. So the real question is we have all this information about individuals in the US and other places, and I'll highlight where we know a lot and where we know very little. But the question is it different in different populations? So we believe that 15 to 20% of ovarian cancer is hereditary, and up to 5 or 10% of breast cancer is. Next slide. So we started working in Los Angeles, and this is going back over a decade. So one of the things I did was at our county hospital, which was in the San Fernando Valley. It's called Olive View. One of my colleagues there, Nancy Feldman, came to me and said, Jeff, I've got 32-year-old Latinas with stage 3 breast cancer who have family history of breast cancer, and we can't get genetic testing for them, yet we're getting it for most of our insured patients. So what did we do? We surveyed the populations in the hospital and found out they'd be interested in learning more about prevention. Then we set up a pilot clinic to try and offer the care to see if they could be engaged. I used bilingual, bicultural genetic counselors. We learned a lot about it, but they actually showed up to that clinic better than they do to my insured clinic. Okay, so they're all uninsured. Then we used philanthropy and grant support to provide testing. Even though the government wasn't paying for testing, we did by our own force, as it were, in our own lab. Next slide. So what we did was in 2005, we published that we learned something. So I was going there to address a disparity, and we found out about patterns of mutations that nobody else knew about because nobody was testing Latinos. So what we found out was that of about 130 families that we had, 31% of them had a mutation. That's huge. That means that we were very selective. That is, women who looked like they were high risk, younger, more likely had triple negative breast cancer. But we found more than we expected in terms of mutations. So clearly, it's a relevant issue for Hispanics. Second, along the way, we found in 2007 that a specific mutation that is not detectable by basic sequencing was found in the first gel we did that was doing what we call a large rearrangement. It's missing exons 9 through 12, which is 60% of the gene. And ironically, sequencing couldn't pick it up. They would just read the normal copy. It wouldn't know that a copy was missing. In any event, we then designed a simple assay for it, which cost us 86 cents to do the PCR assay in 2 hours on the bench. And that we found was 10% of all positives among my patients who have families in Mexico. So we thought, this is interesting. It's never been reported anywhere else in the world. Everybody we found it in was from Mexico. We believe that this must have originated in Mexico. And I'll show you some information that we, in fact, have shown that to be very clear. It's now believed to be 1,500 years old, and it appears to be on a background that has an excess of Amerindian or indigenous American ancestry. So long before the Spaniards, long before other populations, about 74 generations ago. And other data that we did later, which I'll tell you about, was really about when we, usually have that off. That's unusual for me. All right. Anyway, normally so we found out that it was in Mexico City more prevalent than it was in Guadalajara. And so that's consistent with what we found, is that we think it started in central Mexico. And actually, Yanin helped me to figure out exactly where, because she's been helping me to review this. We also went on to look at the pathology of the cancers. We saw fewer progesterone receptors. Some seemed to be some ethnic differences. But we also wanted to know about Latinas and how they prepared and were they able to assimilate the information well. And everything said, yes, they were. Next. So then we looked at broadly at mutations in the United States. This was a publication in JCO in 2013. 746 participants. At that point, the largest study of Latinos in the world. We found 25% of them had a mutation, which again, very high rate. Of those, 15 mutations accounted for over 75% of the cases. So we were seeing the patterns recurring time and time again, which helped us to think about, is there a way we could make a cheaper test by focusing on the mutations that were frequent? Next slide. So what we know about genetic epidemiology, is mostly from the US and Canada, from Western Europe. Australia's got a very well-developed genetics program, and then from founder populations like Israel and Iceland. We're interested, obviously, in South America. Why? Because they are the families of my patients in Los Angeles, beyond all the other reasons that we are. I like to say that we're building bridges, not walls. Next. So what we've done is we have a training program I'll tell you briefly about in a moment. But as part of this, we have engaged sites to work with us as a collaborative research partnership. And what we have is a registry protocol that uses the same protocol to gather a pedigree, biospecimen, and then to follow those patients over time, prospective follow-up. And it gives permission for us to go all the way back to the patient with research-based test results, if they are clinically relevant. So we've used that to enable us to get biospecimens, to diagnose BRCA mutations, and then to get that information all the way back to our Mexican colleagues who are working with us to give that to patients. And so we now have over 2,788 individuals who have been recruited from Latin America. About 1,000 of those are from Mexico, primarily from Mexico City with our previous affiliation with INCAN, University of Guadalajara, and most recently with Tech Salud in Monterrey, and Cynthia Villarreal Garza, who I'm sure most of you know. Anyway, so this is also the opportunity to have Mexican patients appear on the world maps of epidemiology. There was a paper published in Human Mutation, which now features information from those cases. Next slide. So this is one of our meetings of this group, this consortium. Some of you might know some of the people. So there's Julio Abagadas, he's at INN in Peru. There's Cynthia and several of the folks from INCAN, and they're from literally from all over the world in terms of this. Next slide. So we also, because we trained individuals and then give them the tools to do the testing, we came to Mexico City. And so here we are with Talia Wegman. She was a genetic counselor at that time. And there's Kathy Blazer and Cynthia. And this is where we're visiting the clinic and visiting with the patients while they counseled. And we want to see how well they did after having been trained in our program. Next slide. So we also, I love the sign from, they have a national cancer plan in Peru. And I love the fact that the sign focused on prevention. Next. So I want to tell you now about what we did in Mexico City. So the first thing we did after we established our partnership was to work with the group there to develop, and at that time, Alejandro Mojar was the director of the Institute. We had a very good collaboration, and this is just a picture from one of the visits while we were there. Next slide. So what we showed was that we were able to look retrospectively at 96 breast cancer cases and 92 ovarian cancer cases that were not selected for family history. They were treated. They were all young, but they were treated at INCAN. You can see what you all see. Stage 3 breast cancer or above in most of the patients. And as common in the world, most of them were advanced stage ovarian cancer. So that's what we see. So I consider that a disparity because breast cancer in the US, of course, is much earlier stage in terms of the dominant stage. BRCA mutations were prevalent. And remember, I told you about that founder mutation, that rearrangement, the one we think is a founder. And it was a third of the cases. For ovarian cancer, in fact, 35% of the individuals from Mexico City and environs had that mutation. Same for breast cancer. And among women with triple-negative breast cancer, it accounted for 27% of those cases. So this was showing that we now know why some of the reasons why you might see younger breast cancer in Mexico, as well as what proportion of triple-negative might be accounted for by genetics. And again, looking at this, so this is again excess or partial explanation anyway for these clinical findings. Next slide. So we then looked and said, well, what we did was we created a panel called a HIS panel. We did it on a sequenome. And so at that time, genetic testing and commercial costs in the US before the patents expired was about $4,000 for 2 genes. And what were we able to do? We were able to get a test that we could do for $20 that was 75% sensitive. And so this is the old, don't let perfection be the enemy of the good. So we have applied that HIS panel, as we called it, Hispanic Mutation Panel, and we've used it as a way to more economically offer genetic testing where it couldn't be offered otherwise. And so by using innovation in our laboratory and knowledge of specific mutations, and by the way, they'd done the sequencing on the Roche 454 so we could compare the HIS panel to full sequencing, and that was done at INCAN, and we were able to demonstrate the sensitivity prospectively for that part of the cohort. Next slide. And again, this is the patterns of mutations. So at the top is my clinic. Notice on this first column, this very common link of 185 del AG. I'll come back to that. Then horizontally, where it says 9 to 12, that's the large rearrangement. 13 times in my clinic. These are all the different mutations that kept stacking up. Normally, mutations are just random across the gene. But you can see in the middle is a Texas cohort. In the bottom is a Northern California cohort. And the very bottom is our Mexican cohort. So you see they have commonalities. They have common origins, common ancestry. And it turns out that R71G, which is right here, is Spanish and seen in Mexico because of the Spain connection. The first one is 185 del AG, the most common BRCA mutation related to Jewish ancestry. Well, these are multi-generational Catholics. Why am I finding so many 185 del AGs? And we believe that we showed by doing haplotypes, it's on the same haplotype as my West Los Angeles Jewish patients. So shared ancestry, we believe this is the Spanish Inquisition and basically the forced expulsion. And we think that there's a greater diaspora in the New World than had been previously appreciated. And then so all of these, and that this one is very interesting because that, I'm sorry, the next one over, this one, 943 insertion 10, is an African mutation, African American. Why? The slave trade. So what is mestizo? So we're seeing exactly what we predict by ancestral or anthropologic history of a whole peoples. So anyway, so this is the kind of thing we can see that we can then exploit to be able to do testing in a more efficient way. Next slide. So again, founder mutations, next slide. I love this. I went to the Prado in Madrid, and this is Torquemada throwing down a crucifix in front of a Jewish elder who was trying to donate money to Isabel and Ferdinand to get them for their war effort, hoping to avoid persecution. And of course, the rest is history, as they say. You know, huge persecution. Hundreds of thousands of people either perished, converted to Catholicism, perished, or moved on. And then the second was, of course, Galileo. I loved Galileo's last words before he died at the hands of the Inquisition. He says, "She's still round," talking about the Earth being round. So in any event, next slide. So we also wanted to know before we, if we can help integrate genetic risk assessment in Latin America, what are the barriers? And so again, we assembled a smaller group. All of these individuals are from Mexico or South America, and then could help us to understand what are the barriers they face. Next slide. So genetic cancer risk assessment is not covered by most health insurances nor by their family members. Limited lack of referrer knowledge, providers, limited long turnaround time for tests, lack of institutional infrastructure, and then a medical system built to treat disease, not to prevent it. I have to say that's also the US system, other than maybe Kaiser Permanente, but lack of evidence-based guidelines specific to a given country. What can the country afford to do? So these were all considered barriers. And we also got advice from these folks saying, we need to document the problem. Next slide. So we need to document the problem so that we know that it exists, then the policymakers can't deny it. And then we get a chance to start working with that. And even if you can't do MRI for every patient, at the least you can do a mammogram. Now, mammography, I understand, is only about 19% of the population of Mexico. But if we focused on those who needed it the most, you might be able to get some efficiency out of that. Because why did Willie Sutton rob banks? Does anybody know who Willie Sutton is? Yes, because it's where the money is, exactly. That he was a bank robber in the 1940s, and he was interviewed by the press. They said, "Why do you rob banks?" Because that's where the money is. Okay, so same thing with health. If you know that people are going to get cancers, a woman with a BRCA mutation has a 50% chance of breast cancer by the age of 50. And if you don't start screening by earlier than that, you're going to miss all those. So in any event, I think that a multi-layer approach is necessary. And so we're going to talk about our efforts to try and approach that. Next slide. So this is actually Cynthia Villarreal's bookshelf. And why am I showing you that? And Dr. Gutierrez can tell you about this as well. This is her intensive course syllabus when she came to train at the City of Hope. It's a 100-hour course. Next slide. It's a 100-hour course, most of which is by distance. And then you come to City of Hope for face-to-face workshops. And then after that, you get into what we call our community of practice, which is where you continue to get practice support to help support how to practice cancer genetics. Next slide. So we are, that's Dr. Blazer, who is my partner in crime, as it were, to do the training. We've trained over 800 doctors, some representing every state in the United States and 27 countries with, I think, about 24 now, yeah, 24 in Brazil and quite a number in Mexico. So we're continuing to grow the international part of this. Next slide. We've just submitted a grant not too long ago on the dissemination and implementation of genetic cancer risk assessment in Mexico specifically because of our pilot work at INCAN, Guadalajara, and Texsalud. And basically this is just what a figure from the grant showing that we're using tools that were developed, how to train clinicians to do the work, how to give them cheap genetic testing tools. That's what's depicted across the top. So we've down to about $60 to $80 to get full sequencing of BRCA. That's even more, that's beyond that 80% sensitivity I told you about. That's as good as it gets. And we've now actually moved to a multi-gene panel for that same price. So the idea that we can teach them, give them tools, and then use the registry protocol to document the clinical outcomes gives us a chance to both do it right and to make sure that if you build it, will they come? If they come, will they learn? If they learn, will they do the right thing? And if they do the right thing, will they live longer? Right? That's the whole arc, isn't it? From epidemiology to prevention. Next slide. So we have some people in this room who have actually been part of the course already or plan to be part of the course. This is out of the grant. These are folks who have committed to be part of the next wave, as it were, of the dissemination implementation plan. And really we're expanding from beyond Mexico City to, of course, Oaxaca and to all the way to Tijuana and Querétaro. Next slide. So what do we get from that? So this is a highlight. So this is supposed to be a pre-ASCO highlight session, right? So I want to highlight a couple of abstracts that I'm part of. And one of them I'm very proud to have with us here today is Yanin Chavarri. She spent a year with us. Her husband was studying old people and she was studying young people with me. Her husband, Enrique, was working with Arthi Huria on geriatric oncology, and Yanin spent a year with me working on cancer genetics. Can't tell you how impressed I am with her abilities, but we've gone on to look at, in this registry, because we've done these cases, can we now compare how often did people get access to the surgery they needed if they were a carrier, okay? So if they had genetic risk assessment, were they getting the carrier? So next slide. So we investigated the effect of genetic cancer risk assessment on the uptake of risk reduction surgery in Hispanic women with breast cancer enrolled in the registry between 1997 and 2016. Now, all the earlier ones are going to be from the US, and then in the later ones, we're starting to get then our colleagues from Latin America. We compared demographics, contralateral risk reduction mastectomy, so if you get treatment on one side, risk reduction on the other, and then risk reduction salpingo-furectomy. Next slide. So what did we find out? This is Yanin and our data manager, Kai Yang. So 1,517 women we were able to get information on. Median follow-up, 2.6 years. So this is one of the first looks at risk reduction surgery in a high-risk population. We have 270 BRCA carriers in this group and 1,247 who are BRCA negative. And what you see is that for the BRCA carriers, there was more contralateral risk reduction mastectomy and more risk reduction salpingo-furectomy. So risk-appropriate care. Most of it came after the risk assessment. Now, because of the time course of getting genetic information, if a young woman has a strong family history, many of you would simply do a bilateral mastectomy because it was empirical. You didn't have a choice. Or it was the best way to take care of that patient who may go back to their more remote state in Mexico and not have access to the care they might need. So that's perfectly understandable. But this is at least showing the first glimpse at this. And there's also a strategy. We also presented an abstract, what predicted it. So in the US, we were more likely to get surgery than in Latin America. And previous pregnancies were inversely related. Now, that could be an artifact. It could be the women who had previous pregnancies were simply older and thus less likely to get the risk reduction mastectomy. Next slide. Okay, so we also presented at San Antonio this past year on the same cohort, but a different segment, which was to compare risk reduction mastectomy in the US versus Latin America. So overall 39%, but more in the US than Latin America. Same for the salpingo-furectomy. 67% is getting close to where you should be for a BRCA carrier. They should be up virtually 100%, actually. But it shows there's still a disparity. So next slide. Then the other abstract that I wanted to highlight for you. So first off, that one I just showed you is going to be tomorrow afternoon, right, Yanin? So it's poster tomorrow afternoon. Please come and visit the poster. And this one is going to be on Sunday. It's an oral session. Kara Maxwell, I know very well. I'm on that list because this is a consortium. This is related to our registry work, but not related necessarily to our Mexican work. But nonetheless, it's about inherited mutations in breast cancer patients with and without multiple primary cancers. Next. And this is just showing that for individuals who had bilateral breast cancer versus other cancers in addition to breast cancer, showing the difference of different types of mutations that were seen in that case. And not surprising. If it was bilateral breast cancer, most of it was BRCA. If it was breast cancer plus a different cancer, then it started to spread out to different genes that have different spectrums. That's the shorthand. Come by the poster if you want to learn more about that. Next slide. So patients with multiple primary breast cancers, higher BRCA1. Multiple primary breast cancers also have higher mutation rates in other genes, but genes responsible for, but down here, Lynch syndrome genes, for example, colon cancer genes, were only enriched in patients with something other than breast cancer as the second breast cancer. So we're starting to parse out other genes, more complex phenotypes. Next slide. So by way of summary, hereditary breast and ovarian cancer affects all world populations. Common ancestry, geography, and world history are reflected in the presence of founder mutations. The first demonstrated founder mutation is prevalent and likely of indigenous Amerindian origin. The prevalence of the 185 del-AG mutation in these populations is almost certainly related to religious intolerance and the legacy of the Inquisition. Next. So while complete sequencing and rearrangement studies are important, we can accept lesser studies if they get us somewhere. Decreasing cost for next-gen sequencing, I think, will obviate the utility of the panel that we created. Training is important. Need to have training, get the tools, and then we want to enhance access globally. Differences in post-genetic cancer risk assessment uptake of risk reduction surgery may be a reflection of disparities in access. They just don't have access. In fact, when we were at INCAN at their management conference one day, the surgeon put up his hand and said, I can only do 2 additional mastectomies a month. And they had about 40 BRCA carriers queued up to get care. So, you know, the system's going to have to figure out how to manage that risk. By the way, just because you don't know about it doesn't mean the risk isn't there. You're just going to see them at stage 3 when they do come in. And so we can choose to move it forward and be more surgical, more targeted in the way we do this. And strategies to improve the uptake are probably going to be a very important thing to do. This is just acknowledging various funding sources that have helped us to do this over time. But again, I want to thank my colleagues, some of whom are in the room, and the generosity. I've never had a more wonderful and warm relationship, despite my language problems, with the groups that I've worked with in Mexico and South America. Thank you very much.